The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everyone, and welcome to the Flightbridge Ed MDCast. My name is Mike Lauria. I'm an emergency medicine, EMS, and critical care physician, also the medical director for Flightbridge. And I am here today to kick off a new series on obstetric critical care. So as it turns out, very unfortunately, pretty much since like the 1980s, maternal mortality has been going up and up and up, which is very unfortunate. In fact, in the United States today, we've kind of slid to 65th around the world in terms of OB mortality, and we've been on the rise through the early 2000s at about 17.4 deaths per 100,000 to now in 2021 was 32.9. So in the past 20 years or so, we've almost doubled. This in comparison to countries like Norway and Iceland that are hanging out around 1 or 2 deaths per 100,000. So that's really unfortunate. And actually, interestingly enough, critical care transport plays a very important role here because a large number of births actually in peripartum care, about almost 20%, actually 19%, takes place at facilities that don't deliver a lot of babies or take care of many peripartum complications. In fact, they'll do less than about 1,000 deliveries a year. And many of these facilities, up to 37%, are fairly distant from centers that offer critical care services, obstetric services, and the services of maternal fetal medicine specialists, which is actually key, I would say. And so I think what we do see in critical care transport is a lot of these patients being transported from outlying facilities to tertiary and quaternary centers. I also want to emphasize that critical care for these patients doesn't stop at delivery. A lot of the education that we've done in the world of critical care transport and emergency medicine in particular focuses a lot around delivery of the baby. But as far as mom's concerned, more than 65 to almost 80% of major complications and deaths occur after delivery. In fact, hours to weeks after delivery. So I think this is a really important topic, and I think it's time that we really deep dive into some of the education around it. And to help me with this series, I have an amazing guest today, Dr. Elizabeth Garchar. She actually did medical school here at the University of New Mexico, did a residency in obstetrics and gynecology, and just finished fellowship in maternal fetal medicine. We're very lucky to have her, and what distinguishes her for our critical care transport community is she's one of the only OBGYN MFMs that has invested a lot of time in our transport team, has been flying along with us, has been treating these patients at small outside hospitals, and I think really appreciates and understands the world of critical care transport at this point. So much so that we're trying to keep her on as our assistant medical director for our flight program. So I think she's perfectly suited to be here with me and helping out with this conversation. So welcome, Dr. Garchar.
Thank you so much for that kind introduction, Mike. I really appreciate it, and I'm really excited to be here.
Oh, awesome. Before we get started and get into the nitty-gritty, just want to say Dr. Garchar and I have no conflicts of interest. So if we talk about specific medical devices or things during this podcast or other OB critical care podcasts, it's because there's good science behind it, or we think they're good products that can be helpful, and not because either of us are making any money from them. Also remember that we will be discussing some of the evidence and our practice and the protocols and guidelines here at UNM, as well as national guidelines and other scientific statements. But always remember, please, that this is not a substitute and does not override your local protocols, guidelines, regulations, and laws. So by all means, always adhere to them. So today we're going to start out with our first episode, and it is on postpartum hemorrhage. postpartum hemorrhage is actually one of the leading causes of maternal deaths. 23 out of 100,000 OB deaths in 2020 were due to postpartum hemorrhage. And the rates have been rising over the past couple decades, essentially in parallel with the overall maternal mortality rate. And I would say, and the evidence I think supports this, between like 80 and 90%. So the vast majority of these are considered to be actually preventable with aggressive intervention, solid critical care, and prompt surgical intervention. So to start out, let's talk about what is postpartum hemorrhage and how do we define it. So Dr. Garchar, how these guidelines have changed over the past couple years, and today, how does ACOG actually define postpartum hemorrhage?
So ACOG defines postpartum hemorrhage as a loss of greater than a liter in any setting, so either a vaginal delivery or a cesarean section. So previously there was a lower threshold for a vaginal delivery of 500 cc's or more, and they got rid of that and made it uniformly 1 liter. There's also, of course, a caveat of any signs of shock or hypoperfusion, even in the setting of considerably less blood loss, so whatever that patient's threshold is. And I think a lot of that is to represent patients that are anemic at baseline as well.
Gotcha. So that I think is really helpful, kind of streamlining and simplifying a lot of those guidelines. But the question comes up, and things we often ask in the field is like, how much blood has someone lost? And I think it's really hard when you're on the side of the highway to quantify, how much blood has someone lost at a scene. And I think it might also be very difficult under some of these settings. So in the hospital, how do you actually quantify how much blood has been lost and figure out when you hit that 1,000 cc mark?
Yeah, we're pretty spoiled here in the hospital. So we have either equipment that you hold it up and it actually will look at the different things that you have and tell you how much blood is on that, like a lap or a chuck, when you enter what it is. Or in our hospital, what we do is actually weigh everything and then subtract the weight of the dry goods. And so it is a very quantified amount. And that's because we are terrible at actually eyeballing the amount of blood that's lost. So that is a skill that we're taught. We actually take like a bunch of Jell-O and put it on pads and chucks and stuff to see what a liter looks like on like the floor and on chucks to see it. But we are terrible and we usually underestimate. So we are always like, oh, it's just a few cc's here and there. It's not a big deal. And then we'll find they had a hemorrhage of 2 liters quite frequently. So I would say that it is important to quantify if possible, but I agree, really difficult, especially in a non-hospital setting.
Yeah, I think. Would you say that it's practical if you were at one of the outside hospitals that we fly to in an emergency department, where let's say it's a critical access hospital in the emergency department, the nurses and staff there are not used to, say, the labor and delivery setting where the nurses are like right on top of it, measuring every chuck's pad, goes right to the scale. Do you think it's practical for crews to actually say, hey, those sheets, that chuck's pad that this patient is on, can you weigh them for us and can we figure this out? And you think giving instructions and directions like that is reasonable at a small outside facility?
I think it would be. There are actually a couple of QBL websites now that you can put in like what they are, standard medical equipment, things like sheets exactly, or chucks pads. And then you can say how much or how saturated it is, what percentage, and then what the weight is as well. And they can help you get a general estimate. Obviously not as good as these really set protocols, but better than nothing for sure.
Gotcha. And at what point do you think, from a vital sign standpoint, would you basically say, regardless of, as we're quantifying things, you're like, that's a lot of chucks pads, that's a lot of sheets, this patient's vital signs are showing us X. I think there's enough clinically without weighing this stuff to actually quantifying this stuff to say we need to treat this patient for postpartum hemorrhage?
So I would say if there's ongoing bleeding and a decent amount of blood, and oftentimes there's in delivery packs a little thing that catches what comes out basically. And oftentimes that's a lot of amniotic fluid too. But I'll still utilize that if it says that is full to a liter or more and saying like that's a lot of blood and she's having ongoing bleeding. Even if her vital signs are normal, I would want to treat her for postpartum hemorrhage at that point. By the time a young healthy woman has abnormal vital signs of like hypotension and tachycardia, meaning like over 110 and under probably like 90 over 40, 50 even, she's lost a lot, probably like 3 liters at that point. So we treat before vital signs for sure, quite frequently and aggressively.
Gotcha. That makes really good sense. And I feel like that's been overall a general trend in the past 5 to 10 years about being way more aggressive about managing this, as the risks of letting it go too far outweigh the risks of being a little too aggressive and giving some of these medications potentially on the earlier side. Would you agree?
Definitely. Yeah. And that includes transfusion for sure. That's a huge thing that there's a lot of push to not overutilize blood as well. But one of my attendings always says that if we get back their postpartum hemorrhage labs and their hemoglobin's like 10 plus, that means we just did a really good job of keeping them from getting to a dangerous place.
Nice. Awesome. And we'll get more into the drugs and transfusion and all that stuff here shortly. But let's start out talking about some of the causes of postpartum hemorrhage. Pretty much in every textbook and every article, the classic differential diagnosis is broken down to the 4 T's. And would you mind going over what those 4 T's are, and if you really find it to be clinically useful and of utility? And if not, how do you approach figuring out which of those things is really contributing?
So the 4 T's are definitely something that I find useful and sort of remind yourself to go down a little bit more of a path. So tone is the first T, and that I 100% agree. The literature says it's 70% of the cause of postpartum hemorrhage being uterine atony. And this is what it is until proven otherwise in general for obstetric causes of postpartum hemorrhage. And so risk factors for that are anything that further distends the uterus. So having twins, having a really big baby, of course, having a history of it, and then also things that make the uterus not work as well. So things like an infection or a really long labor where they're very tired. So those kind of things are increased your risk of having atony. Trauma is the next T, and that's about 10%. So it is always atony, but if you're still bleeding and you're trying all kinds of things and you're pretty sure your tone's okay because you're palpating it as well, other things to do is look for other causes. So the next T being trauma, I would always do another vaginal exam if I haven't done one recently to see if I maybe missed a pumping artery or a very slow venous bleed. And with that also is laceration of the cervix. That is definitely something that causes women to hose. I've had a lady lose 3 liters from one into the like retroperitoneal space almost, and it was pretty crazy. And of course, uterine rupture too, which is more a clinical diagnosis based on pain and on the fetus's like vital signs as well. You'll lose the fetal heart tones in that point. So any kind of trauma can be a part of postpartum hemorrhage. The third T is tissue, which is 10% again as well. And that I would evaluate really strongly with an ultrasound. So I would look for retained placental parts. And this is something that we should be examining every placenta after it comes out to rule out as well. And so some of the risk factors for this are if we're having a prior C-section and we're concerned for having increased in the myometrial area itself, having the scar that makes the adherence of the placenta different and can lead to placenta accreta. And then also just having things like a subcenturiate lobe, so having a little bit of placenta that's separate from the rest, because sometimes that doesn't come off as well. And then the last T is thrombin, and that's less than 1%. And so that's things like clotting disorders in general. And usually that's something that we've historically looked at, but von Willebrand's being the most common with women that just, they have lived their whole lives, had a little bit of extra bleeding, maybe never had a surgery because they're young and healthy, and a huge postpartum hemorrhage is their first presentation.
Wow. Okay. Yeah, that would be particularly scary. Luckily, some of those are pretty rare.
Right. Super rare. Yes.
So I think from a transport team, a critical care transport team perspective, it sounds like, and please feel free to correct me, is that it is tone. It is uterine atony until proven otherwise. And we should be very aggressive about treating that right up front. If you can feel that the uterus is low and does feel firm and you're still seeing a lot of bleeding, it's time to check out some of the other stuff. I think that a lot of teams these days are using ultrasounds, which is awesome. And that can be helpful, even if you don't necessarily know exactly what you're looking for. If you can get some of the images and send them to the receiving OBGYN or send them to MFM, or potentially show them to the person who's there with you at the bedside, be that an emergency physician or OBGYN from the sending facility who might be able to help out with that. Just obtaining those images may be, in fact, helpful from a crew standpoint. The lacerations and other trauma may be a little bit more challenging. The vast majority of crews are not trained to do speculum exams or examine some of the structures inside the vaginal vault and the cervix, which is okay. I think that's definitely a time where we should be politely encouraging the sending physician to maybe examine that. And if there's something that they find, talking to the receiving OBGYN, if they're not an OBGYN themselves, or MFM specialist to see, because a transport with an actively bleeding cervical laceration may not go very well. That's probably something that I think we should bring up at the sending facility and try to fix at the sending facility as best as possible before we actually get in an aircraft or an ambulance and head out, because that could potentially be a problem.
Yeah, definitely. That's a great synthesis of it. And a lot of that too is, the term uterus is pumping almost a liter of blood through it a minute. So you could be losing like 500 to 750 cc's a minute. So if you're flying a long way, that could be quite terrible. I agree.
Yeah, that is definitely something that we would want to leave unaddressed for half an hour, 45 minutes, or an hour. Interestingly enough, there's, I think, been a push, especially in the world of obstetrics in general, to be more aggressive about preventing postpartum hemorrhage, which includes things like actively managing the third stage of labor. Would you mind talking a little bit about that, Dr. Garchar?
Yeah, so active management of the third stage of labor is sort of just being aggressive after the baby comes out as well. And I feel like a lot of why that has been left to the wayside before is because there can be complications from active management as well, especially for someone who's not trained to be able to remove the placenta. So the biggest, I would say, pitfalls of active management of the third stage are making sure that there's a hand suprapubically that's making sure the uterus doesn't invert and come out. So if you're feeling something on a hand that's above the pubic symphysis, that probably means you're pulling too hard. So pull a little bit less aggressively on the cord. And then the other thing is if you're feeling the cord starting to rip, again, letting up on some of that pressure. So because pulling the entire cord off is probably the least problematic thing that could happen. Inverting the uterus can cause immediate shock and can be really, really dramatic, although it can also be just something you quickly push back in. So that's really the thing to avoid. But when done safely and correctly, which is most of the time, if you just have a hand suprapubically and have gentle traction on the cord itself, you get release of the placenta within usually about 10 minutes. It's normal to take up to 30 minutes for that to happen. As soon as the baby comes out, I always also do oxytocin, 10 units IV or IM. We have a protocol of more of 3-unit boluses here, but that's just our local protocol. But we'll do 2 or 3 generally for everyone to prevent postpartum hemorrhage is the idea, and to help release the placenta. And that's really addressing atony as well is the main thing. So you're having the uterus clamp down immediately rather than waiting for it to do it itself.
Awesome. That was a fantastic summary of the standard practice. And I think this is important too, because relaying this and doing this, if you end up at an outside facility with a mom who's about to deliver and the sending facility is doing it, if they are not already doing some of these things, especially, right off the bat, giving the Pitocin, for example, it's absolutely reasonable, I feel like, to suggest or at least offer to the sending facility, oh, I noticed that you guys haven't given this patient Pitocin. Would you like us to do it, or would you like to give her some Pitocin as part of the standard management of the third stage of labor? Offering that is certainly not a problem. If the sending physician declines or the sending provider declines for some reason, totally okay. We have to do what their licensure is telling us to do, and they may have a very good reason for it. But always something that we should potentially be offering up, or at least suggesting at that point. Now, we've talked about sort of what postpartum hemorrhage is, how to identify it and quantify blood loss. And we've talked about more and more how we're being or trying to be more aggressive to address some of these things. So let's talk about some of the management. Recently, I was at a fantastic talk at CCTMC by the illustrious Michael Frakes from Boston MedFlight, who always gives fantastic educational talks. And his educational talk, he boiled down postpartum hemorrhage management, or what he called the 3 F's: fundal massage, pharmacy, so a play on the actual term, and Foley, which is something that's very important we'll talk about. I like to add a 4th piece of that, which is factors in Fe or iron. In other words, transfusion of plasma and blood products, which is becoming more and more important. So fundal massage, pharmacy, Foley, and the factors. We'll get into some of the details here in a second, but in general, fundal massage and actually bimanual compression can be very, very effective. The evidence to support it is mixed, I would say. However, I think when we talk about utility of doing some of these things, we talk about benefit over risk. The benefits of preventing someone from bleeding to death are significant. The risks of fundal massage and bimanual compression are relatively low. So I think it's definitely something that is within our armamentarium. It is not very invasive and can be very helpful while managing some of these patients. I'll skip over pharmacy for a second, but I do want to touch on something, a mistake that I have definitely made and has been brought to my attention a couple times. And people often ask, Foley, why is Foley part of this management? And the answer is because if there's urine in the bladder, remember that the uterus sits above the bladder in the abdomen. And if that bladder is full of fluid, it's actually difficult sometimes for the uterus to actually contract down and come down. So that is a very simple, very non-invasive thing that most of our nurses and paramedics are very comfortable and used to doing that can actually sometimes make a big difference. A simple thing that can make a big difference. So I keep it in there. So let's get down to the 3rd F, so pharmacy or medications, which is generally one of the highlights, I would say, and the main piece of this that pops up in our protocols that people are familiar with. So let's say, Dr. Garchar, that this patient has already gotten their first 10 of oxytocin, and you have or the sending provider is actually feeling it, and the crew is feeling it. They feel like a big boggy uterus, and there is persistent, ongoing hemorrhage, and you're like, I think this person has a postpartum hemorrhage. I'm very confident that it's due to uterine atony. Where do we go from here? What's the first medication you're going to give as you're doing the fundal massage and getting the Foley in?
I would always reach for Methergin. That is definitely my favorite thing that I like to give right away. The biggest thing is making sure that you don't have hypertension, which I would say is a good quarter of our patients at least, because it can aggravate that. Although I'd also argue that if you have a hypotensive patient that's bleeding to death, that's probably not going to be the worst thing you could possibly do. But either way, Methergin would be the first one that I'd reach for IM, and that is 0.2 milligrams every 2 to 4 hours. And it's something that I would reach for quickly. If I'm just even seeing a little bit of continued trickle, I'd still probably give IM Methergin at that point. And we can give it PO for management as well. And we'll do that in the postpartum setting with someone who we think we've stopped the bleeding, but it's still an overall somewhat atonic uterus. But I would do the IM first for sure.
Okay. And would you add on, if they've already had the first dose of 10 units of oxytocin, would you give them more oxytocin? And then how much more would you consider giving these patients?
Yeah, so we have standard bags that are 30 and 500 cc's here at UNM, and we quote unquote say run the bag wide open. I would say that doesn't really actually happen a whole lot, but they give at least 3 or 4 more boluses, and they don't run it wide open because absolutely open, rapid bolusing of Pitocin does have its side effects, particularly hypotension and hyponatremia as well. So it's something that shouldn't be done with absolute reckless abandon, but is something that we definitely will get a whole bag in someone who we're worried about them having uterine atony specifically.
Gotcha. So do you say giving an additional, in addition to the first 10, giving additional 20 or 30 up to maybe a total of 30 or 40 units over the course of perhaps 15, 20 minutes is a reasonable time frame to have that medication administered?
Yes, definitely.
Okay, awesome. And then when do you think you're going to reach for the carboprost?
So I'll go for the hemobate or the carboprost. If that's not working, essentially, that's not super my favorite medicine. I'd probably actually next go to, in general, misoprostol to add on, especially if I think it's working. So if I'm noticing that the methergin made improvements, but it didn't stop the bleeding, then I would probably do misoprostol. And I strongly recommend doing it buccally or sublingually rather than rectally. The absorption is much different rectally, and it takes about 30 to 45 minutes to work. Where buccally or sublingually, it's much faster and more effective, although it does increase the side effects. So people have become febrile and generally will have a little bit of nausea, vomiting, and chills. So that's pretty uncomfortable, and nurses don't like it a whole lot, and it's a little scary, but it's really important to use it the most effective manner, I think. So that's why I usually push for that, for doing about 600 micrograms sublingually or buccally specifically. But the hemobate, going back to that. So that would be the one, if it's not necessarily working very well with just the methergin on board, you're still bleeding as heavily as you were. And I don't like it for a couple reasons, because it causes bronchospasm, which if you have an asthmatic patient is something that's really hard to fix and reverse. And also because it causes explosive, immediate diarrhea. And it's really awful to be A, transporting someone, or B, operating on someone that's having really bad, explosive, terrible diarrhea.
Anytime I see in the literature or in a warning or hear a provider, with their eyes wide open saying this can cause explosive diarrhea, I mean, that's not the good start to a transport for sure.
Definitely not.
Another drug that's on the list that has gained popularity secondary to a very large multi-center randomized control trial called the Women Trial, which was published back in the Lancet in 2017, is TXA. And in emergency medicine and critical care and pre-hospital emergency and critical care, we love our TXA. It's like the thing that we try and find the solution for. Sometimes it's almost like a drug looking for a problem. But in this case, this was a very large, the Women Trial was a very large study, very well wrought, more than 20,000 patients diagnosed with postpartum hemorrhage in more than 23 countries, with a statistically significant but small risk reduction of about 0.4% deaths due to hemorrhage. Now, that was a secondary outcome. And if you think about it, 0.4 doesn't sound like a lot, but 0.4 out of 20,000 and 0.4 out of hundreds of thousands of women that are giving birth and diagnosed with postpartum hemorrhage could potentially make a difference. If you actually do the math, the number needed to treat, or the number of women that you would have to, with postpartum hemorrhage, you would have to give TXA to save one of them from dying from hemorrhage is about 267, which is on the high side. In comparison, when we talk about giving aspirin to someone who's having a STEMI, which is something we do all the time, the number needed to treat to save one life with aspirin is about 42, and we do that all the time. Again, the effect size was very real. This was a very well-wrought trial with more than 20,000 patients enrolled, and we did say the effect size is small, but definitely very real. So I think the risk of giving TXA to these patients that are actively hemorrhaging is low. The benefit is potentially saving a life. So I think that in addition to all these other medications, it's absolutely reasonable to give the 1 gram of TXA over 10 minutes, followed by the infusion, the next dose of 1 gram over within the next 24 hours, but over about 8 hours or so. Would you say that the OB and MFM community, Dr. Garchar, interprets the study the same way and would agree that giving it is somewhat beneficial?
Definitely. Yeah. I think that it's something that we've tried to indoctrinate to, like, if you think someone's hemorrhaging, ask for TXA to be hung. So it is something that we're trying to really increase because there are so few contraindications. I see a lot of ladies who have had DVTs and PEs because of the nature of my high risk practice. But other than that, other than women who already have a known thromboembolic pathology, really everyone else can benefit. So it's something that we do on everyone, and we try really hard to remember to do. Well,
Nice.
Almost everyone.
Yeah, almost heroin.
Touche.
Yeah. But so it sounds like I think there's a cord, and it appears in essentially all of the guidelines that I can find at this point for managing postpartum hemorrhage. And again, is definitely something we in the transport environment carry for trauma, and some places are even administering it for potential intracranial hemorrhage or diagnosed intracranial hemorrhage. That's a topic for another talk, but I think that it is very common these days to have flight transport programs, critical care transport programs, have that readily available. Now let's talk about upping the ante. So the hemorrhage is going uncontrolled with management. Mom is continuing to lose blood, and now her heart rate is actually starting to go up, and her blood pressure is slowly starting to drift down. Now, although it's outside the scope of practice of most critical care nurses and paramedics, it is certainly within the scope of practice of emergency physicians and advanced practice providers, and definitely some of our OBGYN colleagues at some of these outside hospitals to do things like uterine packing or use balloon tamponade devices. So, Dr. Garchar, this is something you definitely have way more experience in than I do, but what are some of these devices? How do they work? And how do some of these fancy devices actually compare to uterine packing?
Yeah, so I would say that overall the use of the two commercially available tamponade systems, I would say that they're not both balloons, but tamponade systems is something that is on every labor and delivery and is something that we reach for in any instance where we're worried about needing to go to further interventions. So just before the OR, maybe even in the OR. So it's like a last resort thing. But the two devices are called, one, the Bacchari balloon, and that one is a balloon itself that goes inside of the uterus and has saline in it in order to compress the uterus by pushing outward. The other one is the Jada, which is a newer system where they actually suck the uterus in using a suction device. Both of them have ways for you to see how much blood is coming above your device or even with it in place in order to demonstrate, hey, is this effective or is this just a cork stop that's making you not see the hemorrhage that's still going on? But they both are very effective if you're in the point of thinking, I really am going to need to hyst this person. I'm going to need to do an emergency hysterectomy. And I would argue that they're great for especially an outside facility setting where you're not having the availability of an operating room anytime soon. So it would be a great stopover. Both of those devices aren't supposed to be left in for more than about 12 hours, but that's still, it's not like 10 minutes or something. You got time to get to definitive management. I've not had a lot of experience with uterine packing, but looking at how it's compared, it's essentially that if it's an effective way of stopping the hemorrhage, it works well. And most of it can't be really a randomized controlled trial, right? But retrospective studies have kind of said that as long as you can get something in there that can stop the hemorrhage, that can work well. Uterine packing, you would want to use an ultrasound to make sure you're packing into the uterus is the biggest thing, because again, making a stopcock in the vagina and not seeing your hemorrhage is not effective. So making sure you get it really high up there. And I would argue that when I'm doing removal of a placenta, I get my entire forearm almost up to my elbow in a woman to get to the fundus. And so it's a long way. So use an ultrasound, use something to help you make sure you're in the right place. And I would say that whatever you got works great. You could use combat gauze or hemostatic dressings if you have that available. It's not been well studied, but anything that can stop the bleeding without her exsanguinating is going to be helpful in this situation.
Yeah, absolutely. And I think that a lot of our crews, most of them don't have the guidelines or the training to put in these devices or do the packing, but I think it's super helpful to hear from Dr. Garchar's perspective how these things work, if for no other reason to understand how it went in, why it went in, and things to look out for, or so that you can help. A lot of the time, I think what we end up doing is arriving at some of these small outside facilities where they are in desperate need of people who can help them provide critical and emergent care. So, for example, Dr. Garchar was saying, potentially guiding placement of packing or the device with an ultrasound. That is totally something that you can help an outside provider with. You understand what they're trying to do, where they're trying to put this device, and you, by manipulating the ultrasound and showing them the screen, can actually help them get things where they need to go, and they can actually do the procedure. So I think that is awesome to know. So let's say Dr. Garchar, we show up at the outside hospital. They've given all these medications. They've put in a Bacri, or they've done some uterine packing and are actively transfusing this patient. In transport, especially with some of these devices what do crews need to be looking out for as far as monitoring and management of these devices?
Yeah, both of them use like normal saline or just suction. So it's not like you're going to be changing like the pressure of it, which is really great. But the Bacri balloon, the main thing with that one is to make sure to not do fundal exams, because you'll push it right out. So knowing that it's there and that's what it is, and then watching to see how much blood is coming out. It's usually connected to a Foley bag. So they should have a Foley, because you have this giant thing making their uterus push on their bladder, and then also a second bag that has the amount of blood coming out. So that's something to look at to see if that's filling up. And then with the JADA, they actually encourage you to continue to do fundal exams in order to make sure it's still working and in place. So knowing which device is super important, because one, it's actually a way to monitor it by doing the fundals. And with that one, it's hooked directly to suction. So you'll see it coming into your canister if you're having bleeding, with an average actually being only 200 cc's with that device. So usually it doesn't even reach the canister. You have so little blood once you've had it in correctly and it's working.
Okay. Wow. So that's actually super helpful to know. So with the JADA, it may be actually appropriate for intermittently for crews to do a fundal exam to make sure it's still functioning properly, as opposed to the Bacri, which we actually don't want to dislodge from a cervix that has just had a baby pass through it. And we could potentially do if we are continually providing or continually doing fundal exams or fundal pressure.
Right.
Note to self. One other thing, interestingly enough, that's come up in the literature in the past 5-ish years is using REBOA, so resuscitative endovascular balloon occlusion of the aorta. In other words, a balloon device that actually gets inserted into one of the common femoral arteries, goes up into the aorta. The balloon is inflated to occlude flow. And in this case, we're basically placing it in zone 3, so below the renal arteries, which is reducing blood flow to the placenta and in general, sort of the pelvic area. And interestingly, this seems to actually work fairly well in some retrospective reviews and small case studies. So there's not great evidence for it. I think there are some very significant logistical limitations. First of all, this is not, we're not going to see a postpartum hemorrhage every day in some of these outside emergency departments. Not all emergency physicians or providers at some of these outside hospitals have been trained in, have the device at all even available in the institution or facility, and may not be able to or familiar with placing it. However, if you end up in a facility that does have this ability, there has been some very limited literature that shows that flying these devices can be safe, and either with the balloon inflated or even deflated as a precautionary measure, can be delivered to tertiary and quaternary care facilities. So probably pretty rare, but as some of these endovascular procedures become more common, especially with the current generation of emergency physicians coming out of residency, we may see this at some point in the future, and crews should be aware of it. So let's talk, Dr. Garchar. We've tried all of this stuff, and or the hemorrhage has been so bad that an outside OBGYN or potentially a general surgeon decides that we may need to do a hysterectomy. In your opinion, at what point does this come into play, and how do you end up doing it? And then what do we need to be aware of on the transport end?
Yeah, so this is like the last resort. I always say that the best way to scare an OBGYN is talk about accretas and cesarean hysterectomies, because this is our worst, most intense surgery. Blood vessels are about the diameter of my thumb or larger normally. And so you're trying to put a clamp on that and control the hemorrhage from that. And I've seen where we slip off and you lose a liter in a few seconds. It's pretty crazy. So it's something we try to avoid at all costs, if at all possible. But if you're continuing to hemorrhage at the point of where I've tried a Bakri or a Jada and it's not working, you're still having bleeding into that canister, we're going back for probably a cesarean hysterectomy at that point. So I would have probably taken someone to the OR prior, if I could have, to put in those devices and make sure I have ultrasound and availability of lighting and the perfect, situation to look for lacerations, and that I've ruled out any other cause except atony at that point. And then I would do, usually for OBGYNs love fan and steel incisions because it's what we do all day, day in and day out. But a general surgeon might do a general X-lap with a midline vertical as well. And it's just as getting down as quick and as easily as possible. So they do whatever is most comfortable for them. And then it's really controlling the two main sources of blood to the uterus itself. So the infundibulopelvic or IP ligament, which is the blood source to the uterus, between the uterus and the ovaries. And we leave the ovaries in place, and then subsequently getting also the vaginal arteries or the uterine artery that's coming off. And so if you control both of those, you're going to be fine. And then you remove the uterus. Usually with this giant morbid procedure, we leave the cervix in place frequently and take it later. Or if you have just a fabulous surgeon that's there, like especially for us, our gynecologic oncologists, our super specialists, will be able to do the whole thing quickly. In general, I would say we close the abdomen because we're hoping that you've gotten complete control of bleeding before you're leaving. But I have seen where you just have terrible DIC and you can't control it and you leave it open with Abthera and prayers at that point. So if you've, had a closure after a cesarean hysterectomy, I would say there's not a whole lot of different considerations from other post-op patients other than the resuscitation with blood products and making sure that their vitals are stable and those kind of normal things. And I've never had someone fly with an Abthera in place before, but here what we've seen essentially is that we're just continuing to monitor to see what the bleeding is like and then going back in the next day.
Gotcha. So, and for those crew members who are not necessarily familiar with the Abthera device, it's essentially a suction device that goes in. It goes into the peritoneum and sits there and allows has essentially like rows of foam that allow for blood and other fluids to be sucked out, and is attached to essentially a vacuum device for collection of blood and fluid from the peritoneal cavity. So it's essentially sterile either iotaband or other dressings that are airtight that go around it and allows the device to actually suction down. Sometimes what you can see is, especially if it's a general surgeon, they will just have the normal vacuum dressing over the abdomen. That is also possible for you to see. So would you say it's fair at that point, Dr. Garchar, if the abdomen is open, status post-hysterectomy, that you would be monitoring it like you would be any other damage control laparotomy procedure or whatever,
exactly,
quantifying the blood and transfusing people appropriately?
Yes, exactly.
Awesome. That brings us to some specific little tidbits at the end of the podcast here. Medications. This has been brought up in the past. Not all programs have all of these medications because some of these instances are rare. I would say it's not an everyday occurrence that you're reaching for misoprostol, Methergin, some of these other medications, but they are available in almost every labor and delivery that I've seen or been in, and a lot of emergency departments as well, especially critical access facilities. So you can actually request these. It's reasonable to have them in your guidelines or protocols and request them from the sending facility. Blood products, early and often, I would, in fact, if you're getting called for it, a postpartum hemorrhage, and they are not already getting their blood products ready, it would be reasonable to suggest that politely. And I would try and use their products first. Hang on to yours for the ride, because some of these patients do actually need quite a bit of blood. And we didn't dive into it too much, but it is absolutely reasonable to do a 1-to-1-to-1 transfusion to these patients. There's not some disagreement in the literature, or I would say maybe perhaps a better way to say it is not clear, strong evidence as to what the ratio would be. But many guidelines, and I think the practice in our institution and others, would be to just do a 1-to-1-to-1 replacement of transfusion, like a massive transfusion, essentially similar to that we do for our trauma patients. Carefully monitoring these patients en route, I think, is very helpful, especially if there's a device in that can quantify blood loss for us, to make sure we have a very good idea before we leave and over what time course the bleeding has continued. And this, I think we say resuscitation is a team sport with critical special populations, pediatrics and OB patients. It is always a good idea, if you're reaching for multiple medications and starting massive transfusion on these patients, a very good idea to contact the receiving OB or MFM specialist that is going to be taking care of this patient, or the ICU that's going to be taking care of this patient, and make sure you touch base about things you have done and other considerations that you may need to think about en route that may be specific to this particular patient. So we'll sort of wrap it up here. Before I wrap it up here, anything else that you'd like to add about those logistical pearls and considerations, Dr. Garchar?
No, I think that's the most important stuff.
Awesome. So in summary, postpartum hemorrhage carries substantial mortality and morbidity. And what we know is that as we are more aggressive about identifying it and treating it early, the outcomes for our patients will be better. As Dr. Garchar mentioned, ACOG's revised definition, or newer definition, is essentially more than 1,000 liters blood loss, regardless of whether it's a vaginal or cesarean delivery, especially in the presence of ongoing bleeding and definitely evidence of shock. Well, this will, as Dr. Garchar pointed out, be a very late finding in these patients, and we're already behind the 8 ball. When it comes to managing these patients, remember the 4 Fs: fundal massage or bimanual compression, pharmacy, so our drugs, oxytocin, methergin, misoprostol, carboprost, and TXA. And then, of course, the simple intervention of putting in a Foley and draining the bladder. And finally, transfusion, 1-to-1-to-1 transfusion, especially when that blood loss is starting to exceed 1,500 cc's, or we're starting to see alterations in vital signs. And finally, we talked a little bit about some of those devices. Know the devices and talk to your sending provider about what device is in, and based upon that can help you know how to monitor and manage that device during flight. So as we wrap up, I'd like to thank Dr. Garchar. Anything else, Dr. Garchar, that you'd add?
The only one last thing too about that I've gotten questions about fundal massage and bimanual a lot lately is at the sending facility, I'd have the nurse show you where they're palpating the fundus and what it feels like at that point, so you have a baseline. Because I didn't know what like a fundus felt like for quite some time. So having someone show you that's been doing it for, a bit will really help you with that. And then adding bimanual would be having one hand on the fundus itself and then a second hand in the vagina up to the cervix, massaging like the back and the front of it. So it's a really invasive thing. And for both of those, I would argue if the mom isn't trying to fight you off, you're probably not doing it right. But either way, an important thing and something I've noticed recently.
Oh, thank you very much for clarifying that and being a little bit more specific about that particular maneuver. So that, I think, about sums it up. One last thing I'd like to do is put in a plug. I don't make any money off it for sure, neither does FlightBridge Edge or FlightBridge Ed, but Banner University, actually not too far away from us in Arizona, their medical center actually, in conjunction with the Society for Maternal Fetal Medicine, puts on a fantastic course every November called Critical Care in Obstetrics, and it is taught by some of the leaders in obstetric critical care from around the country, literally specialists that are OBGYN, MFM, and critical care, intensive care physicians that teach the course. And it's fantastic. I will put that in the show notes. For now, thank you guys very much, and as always, fly safe.
This has been a production of the FlightBridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.